Hello, everyone. Welcome to our PMAC webinar session on the future society. My name is Rintaro Mori. I'm a regional advisor on population aging and sustainable development of the Asia Pacific Regional Office of UNFPA. Well, thank you very much for participating in our session. The session's title is The Future Society, Population Dynamics Following COVID-19. Before we start, I'd like to actually sort of share a couple of tips for your listening to our session. First one, you may actually drink and eat because this is a virtual session, so don't worry about it. Be relaxed and listen to our conversation. But secondly, you must actually put your questions when you're listening to their talk, speaking, and the conversation. I would encourage all of you to put the questions. There is a question and answer function in this webinar. And I think all of the speakers can lead it through. So we will make sure that all of the questions could be answered. Of course, we might not be able to do that, address all of them. I'd like to give you a bit of a sort of the overview of this session. The COVID-19 has a significant impact on the population dynamics. Particularly, I think one is the population aging, how that actually COVID-19 is going to sort of hit all the persons, and urbanization, and it might be a bit of a migration as well, and the fertility behaviors. So this session is a structure that, there are the three eminent speakers going to talk about guiding us through how the COVID-19 had an impact on three dimensions of the population dynamics, followed by moderated conversations by the eminent panelists. This is actually sort of one of the PMAC webinars feed into the main PMAC event to be held in January. So the results and the conversations and the discussions we're going to have in the next hour or so will be feed into the main conference. Okay, so let's actually get straight into the speech or the recorded talk lectures. The first speaker is Dr. Natalie Lobel. She's a coordinator of the air pollution and urban health of the World Health Organization. So over to you.
Dear colleague, it's a great pleasure to be here with you today through this pre-recorded presentation. And my contribution will be focusing on the impact of COVID-19 at the urban level and more broadly on the possible impact of COVID on the global urbanization process. But I would also like to stress the opportunities that actually the urban context is offering us to address this pandemic and also population's health widely. Please let me start with looking at the broad picture of urban development and its impact on health. And it's not a surprise to any of us that the world is urbanizing. 68% of the population is expected to live in cities by 2050, and this urban growth will be particularly high in low and middle income countries. In cities face a triple health burden with an increase in NCDs and violence and injury, but also at the same time being still exposed to infectious diseases. And cities are also responsible for 60% of both the economic activity and the greenhouse gas emissions. So there are several potential pathways to impact our health and certainly several risk factors for health at the urban level, such as air pollution, noise, water, and many others. And urban areas are certainly to be seen as hotspots for the translation of social and environmental inequalities into health inequity. And if we now focus our attention to the current COVID-19 pandemic, we see that cities are at high risk of COVID-19 and of other health emergencies. And with an estimated 90% of all reported COVID-19 cases, urban areas have become the epicenter of the pandemic. And as another example, according to an OECD report, the COVID-19 pandemic has disproportionately affected migrants who very often live in urban areas. But what makes actually urban areas so unique? And I would like to start with their connectivity and density, pardon me. Cities are very, very well connected to each other. They often serve as subnational, but also national and international hubs. And they do have a high population density. So extensive and crowded public transport networks, for example, and also large communities with crowded and substandard housing do increase the risk of an infection. And urban settings are also unique because they encompass very different social cultural needs and vulnerable population groups, such as population groups living in informal settlements, lacking access to water, sanitation, and hygiene, but also large groups of unemployed people and migrants that I was just mentioning to you earlier on. And then finally, health systems in cities are often referral centers for specialized medical care, and they are at risk of being overwhelmed. While at the same time, they also are very often a point of entry for medical and humanitarian aid. So the unique dynamics of cities impact then their preparedness and their ability to mount the effective response when needed. And actually, many local authorities have governance and policy-making responsibilities that are crucial for their response. And as you can see on this slide, some very practical guidance was developed by WHO and partners, highlighting key considerations that need to be taken at the local level when planning for the response, but also in developing preparedness plans as regards to future possible pandemics. And one key factor to highlight here is certainly that this builds on the need of a strong, coordinated, multi-sectoral approach and across governance collaboration. But certainly, if we want to make sure that this is achieved, there is the need and the opportunity to build and to use tools and knowledge and guidance that do support and push for having urban sectoral policies and interventions being implemented to tackle urban health risks. And here again, I'm moving a little bit away from the specific COVID-19 preparedness and response. And for instance, we have been developing over the years a series of knowledge products on very specific sectors. And you can see here a couple of them. And also some specific approaches and methodologies to support local governments to address health in the urban context. And these tools need to address all the steps of the policymaking process. And this serves as an idea of how actually urbanization, urban intervention can be used as an opportunity. So putting this together and taking again a broader public health lens, it's important to think of health not only as a consequence of what we do or do not do in our cities, but also as a fundamental input for transformation to happen. And this also allows us to articulate a very new approach for the links between health and urbanization, to see also health in general and also health sector in particular as really an input for urban systems transformation for urban and planetary health. And here you can see as an example on the role that urban planning needs to play. So in conclusion, health serves as a key input to unlock new opportunities at the urban level. And while the current pandemic poses indeed many, many challenges to many local governments, at the same time, the current pandemic also offers the opportunity to use urbanization, planning, urban policies to build back better, as this is often stated, and to better prepare for future health emergencies and to understand urban intervention as a real true public health intervention. And deepening the knowledge on how special planning can control disease vectors and influence disease transmission, including, for emerging infectious diseases, is a key step to take. And so certainly, finally, the allocation of investments and the policy decisions that, will guide both short and long-term recovery will certainly shape the way that we live in cities for the years to come. So thanks a lot for your attention and looking forward to the discussion.
Thank you very much, Natalie. Dr. Natalie, to talk about the COVID-19 impact on urbanizations and vice versa. I think Natalie, actually, Dr. Natalie is going to remain actually for the moderated conversation. So she might be able to elaborate more on that. So next speaker is the Miss Elizabeth Wilkins. She's a doctorate of the Institut National d'Études Démographiques in France. And she's going to talk about the human fertility and the COVID-19. So over to you, Lizzie.
Greetings to everybody watching today. I'm delighted to present research commissioned by UNFPA Asia Pacific Regional Office on the impact of COVID-19 on human fertility behaviour. Unlike the morbidity and mortality aspects of the pandemic, the impact on fertility remains less explored. But these impacts are also important to consider, particularly from the perspective of individuals and the choices they're able to make about childbearing. In response, UNFPA APRO commissioned a literature review and accompanying report to explore the potential impacts of COVID-19 on fertility, based on evidence from proxy situations such as past epidemics, recessions, and societal upheavals, as well as early evidence from COVID-19 itself, supplemented with case studies from countries in the region. Now, importantly, this is not the only review on the subject, and other excellent summaries exist. You'll see 2 references here. But broadly speaking, all have converged on similar conclusions. The first vital point to make is that there is huge uncertainty associated with the impact on fertility. COVID-19 comprises a unique combination of factors that haven't been seen for past public health crises. Secondly, we're still in the midst of the pandemic. And thirdly, there's a 9-month time lag between conceptions and actual outcomes in terms of births. So we have to be really cautious. And our aim in the review was not to make firm predictions about the impact, but rather to say, looking at the literature, what are some of the key dimensions of COVID-19 that also have the potential to impact fertility, and how might they do so? We identified 5 key dimensions, but we'll focus on the 3 main ones here. Number 1, the impact on access to family planning. Number 2, the impact on gender norms and the division of labour in the home. And number 3, the impact on economic recession and uncertainty. Crucially, the impact is unlikely to be uniform, both between and within countries. At the country level, we can distinguish between 2 broad extremes of possible pathways. On the one hand, in low-income contexts, and on the other hand, in high-income contexts. In low-income countries, where family planning systems may already be fragile, and where the pandemic has led to further disruptions through disruptions to supply chains or the closure of clinics, for instance, we might expect to see an increase in unintended pregnancies in 2020 and 2021. In addition, there's evidence that the pandemic is leading to a reversal in women's empowerment, including a rise in intimate partner violence and a strengthening of traditional gender norms, with women confined to the home. This too has the potential to impact on fertility, perhaps leading to stalled fertility declines in low-income contexts. The impact of economic recession and uncertainty in these settings is very difficult to predict. Turning to high-income countries, at least at the population level, we're unlikely to see significant disruptions in access to family planning. However, in these contexts, the unprecedented increase in working from home, coupled with school closures, is leading to an increased domestic burden that has fallen largely on the shoulders of women. The increased opportunity cost of childbearing that results could be expected to lead to a decrease in period total fertility rates, at least in the short term. Economic recession and uncertainty could also be expected to lead to the postponement of long-term binding commitments such as childbearing, further contributing to a decrease in period total fertility rates in the short term in these contexts. In reality, most countries are likely to sit somewhere between these 2 extremes on a spectrum, with the impact conditioned by government policies, institutional environments, and also cultural factors. Importantly, within countries, the impact is also unlikely to be uniform, with those already vulnerable groups, such as the poor, marginalised communities, as well as informal and migrant workers, facing the greatest constraints on fertility choices. So what does this mean in terms of policy? How might governments mitigate some of these constraints on fertility choices that the pandemic has exposed? First, by addressing barriers in access to family planning, through designating it as an essential service, strengthening supply chains, and exploring delivery methods such as telemedicine. Second, through addressing unequal gender roles and the division of labour in the home, through provision of affordable and accessible public childcare services, flexible working options, as well as behavioural change workshops and campaigns. And thirdly, through addressing the effects of economic recession and uncertainty, through job retention schemes and strengthening social welfare systems. In conclusion, the response to COVID-19 offers an unprecedented opportunity to recognise and address key barriers to fertility choices for the current pandemic, for possible future pandemics, and more generally beyond. Thank you very much for listening, and we look forward to sharing the final report on the UNFPA APRO website soon.
Thank you very much, Lizzie, to talk about the potential impact of COVID-19 on the fertility and fertility behaviors. Next one is the COVID-19, particularly COVID-19 impact on older persons. Ms. Adelina Comas Herrera is going to talk about the COVID-19 in older person. She's an assistant professional research fellow of the Care Policy and Evaluation Center of the London School of Economics. So over to you, Adelina.
My name is Adelina Comas Herrera, and I'm a researcher at the Care Policy and Evaluation Center at the London School of Economics. Today I'll be talking to you about COVID-19 and its impact on older people. So I'd like to first of all acknowledge all the people who have contributed to reports through the LTC COVID website, including my co-authors in some of the reports I'll be showing. The LTCcovid.org initiative was a spontaneous international collaboration to share learning on COVID-19 and long-term care. It has a number of international reports, country reports, as well as a collection of resources, summaries of emerging evidence, and a directory of research projects, and it welcomes additional contributions and volunteers. We're all learning from each other at this crucial time. First of all, just as we know, COVID-19 affects older people much more. They have a much higher probability of dying if they are infected through COVID. And I'm showing here this graph that shows that compared to the average rate of mortality in the countries, the people aged 65 and over, particularly men, have a much higher probability of dying across all countries. You will notice that there's one country that looks a bit different with an even higher rate, that is Brazil. I'm not entirely sure what the difference is due, but all the other countries that are listed here are high-income countries, except for Brazil, and it might be that that has something to do with it. The source of this document is a recent study by Yanev et al. So knowing that older people are more at risk, it may not be such a surprise that we have found that a large number of the deaths linked to COVID have happened among care home residents, among people living in care facilities. And this is a contrast, the fact that we have, at least for high-income countries, just about half of all deaths in care homes, when only 0.75 on average of the population are living in those care homes. So why has there been such a large impact on this care home population? And there are some potential explanations that I'm just briefly going to mention. Some of it is because of the high risk of the population. As we said, they are older. This virus affects more older people, but they also live in crowded living conditions. They live in a congregate setting. And that means that it's very difficult to apply any kind of isolation. And they also, in large numbers of the people living in care homes, need close contact care. So they'll rely on personal care provided by somebody who has to be close to them to provide it. But we've also seen that there have been a lot of problems with the policy responses, particularly in the first waves of the virus, with late and insufficient access to testing and personal protection equipment in care homes, late adaptation of guidance to recognize the geriatric COVID symptoms such as delirium and also the possibility of asymptomatic transmission. We've also seen examples of reduced access to healthcare. We have found that there's a very high correlation in the deaths happening in care homes and the deaths happening outside in care homes if you look at the shares of the population. And that's telling us that the measures, particularly we adopted in the first wave, didn't really help that much in terms of protecting those living in care homes from having the disease and then dying. But we also know that COVID-19 has affected very severely people relying on care who live in the community. So we know that they've been using less formal care services, and that will be because of less availability of service or the need to quarantine. We know that informal and formal carers were often not recognized as key workers, and we know that there's been a lot more burden and stress and financial strain for unpaid carers. And we also know that there have been a lot of deaths happening in homes that may not have even been recorded as COVID, and this may have been due to people having care needs. And in fact, a lot of this excess mortality has been happening among people who have dementia. So what have we learned? There's a really good World Health Organization policy brief setting out lessons from initial lessons for a number of countries. And we know that there is some hope. So we know now much more how important it is to develop emergency responses that take account of older people and people with disabilities. We know that there's a bit less mortality in care homes in the second wave in some European countries. So maybe some of the things we have learned have been put into practice and have been successful. And of course, in many countries, we now see a prioritization of people living in care homes for vaccines. And I think a consensus is emerging on the need to modernize care systems so that we can strengthen community-based care. Thank you very much.
Thank you very much, Adelina, to cover the COVID-19 impact on older persons, particularly focused on the long-term care facilities. Now, we have a better idea on the sort of COVID-19 impact on population dynamics, particularly focused on three aspects of population dynamics. One is an urbanization, plus a little bit of migration. The second is the fertility behavior. The third is in the aging and older persons. Now, I think we're going to have the moderated conversation of the panelists, eminent panelists from now. And the moderated conversation is going to be moderated by Professor Stuart Baston. He's a professor in the Division of Social Science and Public Policy of the Hong Kong University of Science and Technology. And he's actually also the director of the Center of Aging Science. So over to you, Stuart.
Well, thank you very much indeed, Rintaro, and a very warm welcome from Hong Kong to panelists and most importantly to our participants from all around the world. My name is Stuart Baston, and it's my pleasure to be able to moderate this discussion. Before we start, I just want to begin reading a brief statement from the co-chairs of the PMAC International Organising Committee about the pandemic. The COVID-19 pandemic has taken a huge toll on lives and livelihoods, disrupting health systems with impacts going far beyond the disease itself. It has impacted the progress with the Sustainable Development Goals. The global economy is in recession, pushing millions back into extreme poverty, and social and political fault lines have been exposed. It has worsened pre-existing inequities and has disproportionately affected the vulnerable and disadvantaged. These inequalities, poor governance, and the politicization of public health are putting people at risk. And to date, the pandemic has claimed more than 1 million lives. So I think in this vein, it may be appropriate for us just to pause for a few seconds to think about all of the people that we have lost to COVID-19, and all of those individuals, families and communities around the world who have been and continue to be affected by this, as well as all of those working selflessly and tirelessly around the world to support those in need. So thank you very much. So as we move into the next part of this session, then I'm delighted to be able to introduce a tremendous panel of experts who are going to reflect some of the findings of the videos that we've discussed so far, as well as to answer any of the questions that you pose, which you may do on the Q&A function there. So firstly, I'd like to introduce Dr. Tallulah Oni of the University of Cambridge. Dr. Oni is a public health physician scientist and a clinical senior research fellow with the MRC's epidemiology. I'm a demographer, I can't say epidemiology. Epidemiology unit's global public health research program. And Dr. Oni is one of the world's leading urban epidemiologists and has worked extensively both across disciplines and with a very strong public policy application. And in particular, high profile work on urban health research in Africa has been recognized by publication in the top journals and with various awards and fellowships. Secondly, I would like to introduce Eduardo Klein, who is the regional director here in the Asia Pacific region of HelpAge International, which is of course a global network of 158 organizations in 86 countries, all of which are collectively supporting millions of older people to live safe, dignified and healthy lives. And Mr. Klein has tremendous experience working in the field of aging and policy, especially in Southeast Asia, with a special focus on policy development, aging research, community-based programs and support systems for older people. And then finally, we welcome to the panel Dr. Natalie Ruebel, who was briefly introduced by Rintaro, but it was a little bit concise, so I'll say a little bit more. I'll just add that Natalie is the coordinator for air pollution and urban health at the WHO, and prior to this was a technical officer in the Department of Public Health, Environmental and Social Determinants of Health at the WHO in Geneva. And her main work was at WHO, housing and health guidelines and efforts to address slum upgrading through housing policies and other social policies and interventions. So before we begin, just a quick reminder for all of our participants around the world to please pose any questions in our Q&A function there, and we will ask the questions to our panel. Okay, so let's get cracking. And so firstly then, may I turn to Dr. Oni, perhaps if she might be willing to introduce a little of her most recent work on population dynamics and COVID-19 on the theme, especially in the urban context, and perhaps to reflect a little bit on some of the issues that were raised in the videos presented earlier.
Thanks very much for the kind introduction, and to the earlier panelists for shedding light on some of these important matters. So I focus on urban health and the public health and epidemiology perspective. And it's been interesting. So what I will do is just share some reflections, right? So I've been working primarily in cities across the African continent around strategies to create health and really address the upstream determinants of health. Prior to COVID, so a lot of this work has been prior to COVID, and necessarily, in public health, we are very good at talking about the fact that the majority of factors, 80% of factors that influence health, lie outside of healthcare, and yet a lot of our focus when we talk about creating health focuses on the healthcare. So a lot of my work is recognizing that the actors and the people who have a critical role to play in addressing health inequalities in cities, particularly rapidly growing cities, do not actually fall under the health sector badge. So we're talking urban planners, transport, architects, and mayor's offices, etc. Some of the key challenges that we identified before COVID is really around the agency to effect change at a systemic and institutional level. So it's, you're not going to come across anyone saying health isn't important, right? That's the beauty of health, is everyone knows it's important. To varying degrees, some of our research found that the awareness in different sectors about the roles that they play in the risk of disease vary. However, a cross-cutting perceived barrier was really about the mandate to do anything about it. So we have this siloed mandate. You know, I work in housing. My mandate is to deliver housing. As long as I do that and tick that box, that's okay. I can't really do anything else. I'm not assessed on doing anything else, etc. So there was this rigidity in this is how we do things. It's really how do we start to think about changing it as a systemic level. And then COVID comes along, right? And one of the things that is being really remarkable is the level of exigence that this has resulted in. So just the urgent and immediate action in different sectors working together. There's not an example of any sector saying, oh, well, COVID, that's health, right? That's nothing to do with me, right? So it very quickly became apparent that all hands need to be on deck. It also became apparent that this was possible. I reflected a few months ago in a piece on the things, on all the impossibilities before COVID that it turned out were possible. Things about intersectoral action, things about the role of civil society and government in protecting health, etc. But then that's something that's relatively easy to do when something is perceived to be urgent and immediate and an emergency. And in this context is this pandemic. But a lot of the work I do, for example, it looks at strategies in cities to make healthy eating and active living more accessible and more feasible, right? And those address the critical pandemic of non-communicable diseases and obesity that has been going, and it's global. But yet there isn't this urgency and this critical feeling of having to act now. And part of the reason is because we have this disconnect in time and space between exposure and outcome. So reflecting on lessons learned from COVID, if COVID had an extended period of between exposure and outcomes, would we have had the same level of collaborative action? And that's important to reflect on because we need to address some of those disparities. Listening to Dr. Rogel's presentation, three things strike me as cross-cutting, whether we're talking actually about urbanization or in fact fertility and reproductive rights or rights of older persons going forwards that we will need to address. The first thing is complexity, the second is uncertainty, and the third is inequity. The reality is a lot of these issues of creating health and protecting health exist within complex and adaptive systems that we need to engage, and we need to engage with that complexity. The second is that in beyond COVID, you know, we talk about COVID as if this is the first bout of uncertainty that we've had to navigate, and certainly it is in recent times in the global context. But if you look at rapidly growing cities where there are huge inequalities and rising informal settlements, etc., you have people navigating these uncertainties, be that social, economic, environmental, on a day-to-day basis. And a lot of that has been largely ignored when we think about strategies to address health inequalities. And the last is about the inequities. When we think about protecting health, there has been insufficient focus on thinking about who for. We've learned a lot of lessons, and there's been a lot of narrative highlighting vulnerabilities and differential exposures and consequences and susceptibility to COVID. And yet when we see in the current climate talking about the vaccine, the COVID vaccines, we're seeing the same issues playing out again, which is that inequality is not being front and center in terms of prioritizing who should receive vaccines. So it's really important that we set out front and center what these critical issues that we engage with, because learning from them is not a given. And the last thing I would mention to reflect on in this discussion is a rights-based approach, right? So the right to health is something that is enshrined in the in UN documents that quite a number of countries are voluntarily subscribed to. But often when we talk about a right to rights to health, the focus is around essential medicines and healthcare, and those are critical components. But also in that document in General Comment 14 is also the right to recognizing the rights to minimum food requirements, recognizing the right to healthy housing and work environments as critical to the right to health. And so if we were to examine how different countries and cities have played out in terms of the upholding of the rights to health in their response to this epidemic, I think that would be quite telling and quite instructive in how we go forwards, particularly in the context of addressing the most marginalized. So I'll leave it there. Thank you.
Thank you so much, Dr. Oni. I wonder if now I might pass over briefly to Mr. Kleen. So we heard in the presentations how in many ways older persons in particular, but also older persons with multiple vulnerabilities are particularly at risk under the circumstances of COVID-19 at the moment. Mr. Kleen, could you tell us a little bit about the work that HelpAge International is doing in different parts of the region and around the world, and how and the so on the ground how the organisation is having to adapt and respond to the pandemic?
Thank you, Stuart. Yes, we tend to see older people as a homogeneous group, and we also tend to equate old age to vulnerability. But COVID has shown that although there is a large segment of the older population that is vulnerable, that are prone to disability or have other non-communicable diseases, there is a growing segment of the older people population that are reaching old age, well educated, with in relatively good health, and with the legitimacy and leadership in their communities. Now, why do I mention this? Because early on, I remember January, mid-January or so, we started getting requests from the older people associations in China, specifically in Xi'an province, where we have some network members, no? Asking for some advice and support, and asking for masks and CCTVs that we could send from other parts of Asia. Well, that was an interesting situation, but gradually we went to understand that the old network of older people associations and the community-based organizations, conformed largely by older people, especially in rural areas, were having a crucial role in ensuring that all the measures that were completely new, that using masks and social distancing and not having gatherings of older people, were being enforced. In the successive weeks, we observed that older people were playing such a positive community active role in India, in the Philippines, in Thailand, to mention some cases. So we needed to shift our thinking from this older people as vulnerable segment, as a blank tabla rasa approach, to understand that there was a huge potential in terms of ensuring the social connections and social support at community levels. In Vietnam, it took 2 weeks after the lockdowns in Vietnam before the older people associations were taken in Vietnam, mainly in rural areas, but also in urban areas, were starting to deliver again the home care programs that are quite extensive in that country and some other countries in the region. So once the measures were understood, the social distancing and the preventive measures, then the care of vulnerable people by other older people was resumed. So that was one interesting thing to note. The other, we did together with UNFPA monitoring reports, monitoring analysis in 8 countries in Asia. that go from Afghanistan, India to Southeast Asia, and including Japan. No? And we observed a few things that I want to highlight. One is the paucity of data. There is huge scarcity of data, disaggregated data on old age. In some cases, it's 60 plus, and then they don't disaggregate the other age brackets. Not disaggregated between older men and older women, not disaggregated between cohabitation or the residential settings. No? So that was a factor limiting the analysis. Another point that I want to highlight in this report is that the impact to older people was different from what was expressed generally in Western countries, what was happening in Western countries. For example, and Adelina can add to this, no? But the deaths in long-term care facilities throughout the region, throughout Asia, were much lower than in Western countries. Of course, there are two factors: that the proportion of population, older people living in care facilities, is lower, and most age at home. But even in countries with have high levels of people living, high proportions of living, similar proportions to Europe, living in long-term care facilities or care homes, the proportions of that were much lower. And that has to do with the capacities, even as I said, in Japan or Korea, the capacities of the state to, and the general capacity of the society to deal with the pandemics. I would say even the social discipline, that's a term that can be misinterpreted, but there is some sort of social discipline. Other factors that were analyzed in this monitoring reports that are being finalized this December is the impact of inequalities. Inequalities has been very deleterious. Inequalities in access to information, inequalities in access to health, inequalities on for example, that we could see in India. We could see older people having relatively secluded places or having faring fairly well with the family in lockdowns. And on the other hand, we saw hundreds of thousands of people roaming through the roads, going back to their homes, into their villages in India, at the most appalling situations of deprivation and poverty were seen in that context. The other is the direct, and the last point I want to make on this monitoring report is the direct relation between the negative impact of COVID and the state systems, the strength of the state systems. For example, countries with universal health care, namely Thailand, universal health care with village health volunteers all over the place, or China, or other countries, have had a lower impact of COVID on older people and on the general population. Or countries which have universal social pension systems established have had much easier, much better way to reach all older people in terms of the support system, the income support that was delivered in several countries. Finally, in general, to understand the real impact of COVID, we will need to. It will pass some time, Zhou Enlai once was asked in the 1970s, what do you think of the French Revolution? And he said, it's too early to say. And I think the real impact of COVID is still too early to say how it is altering certain patterns in society, certain relations in society. More so, therefore, the challenge to better understand now, what do we mean by building back better? Everybody's talking about building back better, not returning to the past. But I'm afraid that the inertia of the past is being very strong, and we still are not seeing ways of building back better in terms of income security, in terms of health, access to health or adequate health, in terms of environmental conservation and the roles of older people. So we have many questions, few answers, but we also have the certainty that older people and the 600 million people in Asia who are in the old age category will play a crucial role in the future of these societies. Thank you, Stuart.
Thank you very much, Mr. Kleen. And actually, this is a lot of the themes that you talked to there, of course, were the same which came up in Elizabeth's presentation, for example, about the uncertainty. You know, we're talking about something which we don't even know how long we're into this, right? How much longer we are, the uncertainty going forward, how we may well be having very different institutional responses in different parts of the world, different cultural responses. And also, I think to go back to what you said right at the start, the key importance of this, not just assuming certain vulnerabilities among certain people. We have to think of this both across the life course. So the life course approach taken by UNFPA, I think, is very helpful in this, but also the other characteristics, of which age is just one, not a very good characteristic, not a very helpful characteristic, chronological age. We've discussed various different groups, but I would like, if I can, just in the last few minutes to bring in Dr. Roebel. One group which I always feel as demographers, we tend to talk about less, and as policymakers, I think, tend to consider the least for various reasons, is migrants. And we've seen in various different parts of the world how migrants really have had a particularly rough time over the last few months. So I wonder whether or not, I know because you mentioned migrants in your presentation, Dr. Roebel, could you maybe elaborate a little bit more on the work that WHO is doing with regard to migrants under pandemic circumstances?
Thanks, Stuart. Thanks a lot. And I don't want to take too much, the floor, as I had the opportunity to speak, but thanks for, allowing me to spend a couple of words on the particular situation of migrants that indeed are a key vulnerable population groups in these times. It may be just to look at it a little bit more broader. We know that today, we are estimating 1 billion people who are on the move, with more people than ever actually migrating or being displaced. So if we look at it specifically, it's about 1 in 7 people worldwide. So it's a huge number. And population movement have actually increased over time due to conflict, persecution, degradation, environmental degradation, but also due to a profound lack of human security and opportunity. And this is referring back to some of the points, right, that were mentioned earlier, and Tolu also mentioned them. So refugee and migrant situations continue actually to increase in the scope and the scale. And again, to bring back one of the terminologies that Tolu was using, in complexity. And if we look now at the specific situation that we are facing today, so refugees, migrants, but also internally displaced persons, we shouldn't forget them, are among the most vulnerable populations that are hardest hit by COVID-19, and particularly those in fragile and conflict affected settings. As well as those that are in irregular situation. And this is, again, particularly relevant for the urban context, because a lot of migrant populations then do live in the urban context. So those refugees, and also those under international protection, they really face significant obstacles in securing, third country solution, very often due to border closure, but also to travel restrictions. And COVID-19 certainly did not stop people from fleeing violence and persecution, as I was saying before. So the fact that lockdowns, restrictions of movement, and social distancing measures were implemented worldwide to contain the spread of COVID-19 has again actually disproportionately affected these very vulnerable population groups. And even though refugees and migrants can be exposed on COVID as one of the host population, they have actually at the same time very limited tools to protect themselves. They may live in very insecure settings without access to essential health and other services. And interesting though, also at the same time, they are also those that during the pandemic have also played a significant role in the contribution to essential services, particularly in the sectors of healthcare, retail, transport, food chain, and and other services due to the illegal employment constellations. So I think in a nutshell, and this is again, I would say, elevating the discourse from the current COVID situation and putting it, in the broader public health agenda, investing in refugees and migrants' health is actually a key approach that needs to be taken to controlling and managing pandemics, but also for addressing health needs of migrants as part, of broader global public health and universal health coverage approaches. So again, it shouldn't be seen only, as a specific priority to be looked at during COVID. Certainly the COVID pandemic is enhancing the very precarious situation of migrant populations, but this is something that needs to be put, in the broader health context. And indeed, there has been a draft global action plan that was developed by WHO that it's looking at the period from 2019, 2023, which really has the objective of supporting countries to include policies and services that include and reflect the specific needs of refugees and migrants when developing preparedness plan on one hand, but also broader public health plans. And this action plan really aims at supporting countries with trainings, with interventions, with analysis of good practices and best cases examples. So a lot of work there. And Stuart, if you just allow me one additional sentence, just building on what Tolu was saying. So I'm moving a little bit away from the migration aspect. Tolu was speaking about complexity, uncertainty, and inequalities, in particular that when we speak about demographic, and public health, we need to see health not only as a health system, health care approach, but a determinant approach. And I think that from our perspective, this is something really that needs to be further invested in, like housing, as one of the key entry points. It's important to see housing as a key public health intervention. And we developed guidelines some time back. And if I have the opportunity at the later stage to speak about the experience that we had, is really showcasing how complex actually this topic is. So over to you, Stuart.
Thank you very much, Dr. Rubel. So I think as I can feel our colleagues in the PMAC Secretariat getting a bit twitchy on the time here. So I will pass straight over to Dr. Oni just for 2 or 3 minutes of just closing remarks. But I would just be curious, because one thing which you mentioned really stuck with me, that we have seen this all hands on deck, this multi-sectoral, intersectoral, interdisciplinary approach. And I just wonder, how hopeful do you think this might continue, or is this just a one-off? Like, okay, it can be done, but it's never going to happen again. Do you have any hope that that this might go on in the future?
Always have hope and always optimistic. But someone said optimism is informed hope. So the first step is to inform ourselves, and this is why these conversations are important, not just to talk about all the great things that have happened in response to COVID, but also to reflect on what is all the impossibilities that we've made possible and how that could continue, but critically why that hadn't happened in the first place. So I think it's important when we think about, I always get twitchy. There are 2 words that make me twitchy. The first is recovery, and the second is resilience, and I'll tell you why. Recovery, because we know that the state of things before was not working, right? We know that the risk of emergence of new diseases is in part driven by anthropogenic activities, encroaching into natural and disrupting the ecosystems. We know that the exposure and vulnerability to ill health was inequitably distributed. We know that these systems that were in place are almost working by design to perpetuate inequality and vulnerability for some. So it makes me twitchy when we talk about recovery, because we don't actually want to recover into that. We want to reset and rethink and pivot. So let's talk more about pivot. Just two quick reflections on the interventions by the other panelists, to add to what has previously been said, that came out was the importance of measurement and contexts. So measurement matters, we know this. We can't act on what we don't know, but often we end up with this perverse valuing what we measure and not measuring what we value. The conversations around old persons, etc., really highlighted the importance of, if we think about what we value, then we think about, well, how do we measure that? And if it's difficult, we find a way. That's why science is so great. The second is the importance of context, and that was really struck me in thinking about reflecting on the performance of different countries to the COVID pandemic, and some of the countries that performed better had, apart from universal health coverage, greater participation and recognition of the different contexts that are playing out in those settings, and responding to those. So those obviously go in hand, because if you're not measuring, you're not aware of those contexts. So in thinking about pivoting post-COVID, I think is important that we recognize what it would take, right? So the response and where we've got to at the moment would not have been possible without this whole of society, whole of government approach. So we know what it would take to address the other complex challenges that we face. As I mentioned, the pandemic of obesity, non-communicable diseases, but importantly, climate change. So this is a pandemic and a critical emergency that we have been very slow / have inertia. So the second point in pivoting is the importance of prevention. And this brings me to the reason why resilience sometimes makes me twitchy, right? Because we talk about resilience often limiting it to reactive resilience. So holding constant, we assume people are vulnerable. How do we protect them against the worst of it? But often we forget proactive resilience, right? So a lot of that vulnerability and marginalization is not inevitable. And so as much as it's important that we gear our systems up to protect the most vulnerable, we also should be asking why they are vulnerable and how we can be resilient enough to reduce that vulnerability. And so that is really, I think, more comprehensive aspect of thinking about resilience. So lastly, the importance of this coherence. And this is where complexity comes into play, right? So we know that different parts of society have a role to play and absolutely must play a role. At best, often they're not playing a role, so we have an ineffective response. At worst, and this was often the case pre-COVID, we have different aspects of society working against. So you have a health sector that is trying to address healthcare needs, but you have a trade sector or a transport sector that is increasing air pollution and is increasing burden of disease. So we need to have coherence around both human and planetary health. So I think I will end with that reflection, so that we think about resilience of how do we make the COVID interventions that have been put into place to protect the most vulnerable and to reduce exposure and to reduce susceptibility and consequences of ill health. How do we make those interventions resilient? Because that is how we can, in the long term, shift our trajectory towards a more healthy and sustainable future.
Well, thank you so much for those remarks, said Dr. Oni. And it's actually very pertinent, because in our Centre for Aging Science here, we are, and also with UNFPA, thinking about how we can learn, or bridge those scientific learning from climate science, right? We can think about adaptation, resilience, adaptation mitigation, and as you say, resilience, but a proactive resilience, right? And developing that for population processes, not just for carbon, right? We can actually think about this in a social process as well. And with UNFPA APRA, we've been doing a lot of work in that area as well. Anyway, I've completely run out of time because I'm a terrible moderator. So I apologize, everybody. We had our first question came in at 4:58. So I'm afraid, or at Hong Kong time. So I'm afraid it's a little bit too late for us to answer that. We can move on to the very last thing, which is a nice thing I do, which is just to say very big thank you to everybody. Thank you to our PMAC secretariat. Thank you to Rintaro for organising and inviting us all. Thank you to Dr. Rubel, to Ms. Wilkins, to Ms. Comas Herrera, to Dr. Oni, Mr. Clean, and of course, Dr. Rubel from the WHO. Thank you once more to everybody. Thank you to our participants around the world. And we wish you a very good rest of the morning, rest of the evening, whatever it may be. Have a wonderful day. Okay, all the best and bye-bye.